Hi, I'm Dr. Anita Soni. I am a full-time consultant obstetrician and gynecologist and in charge of the high-risk pregnancy OPD at the Dr. H Hiranandani Hospital in Mumbai. Pregnancies have gone on from the times of Adam and Eve and will go on till thy kingdom come. But what makes it actually different today is our lifestyle and the complications which have been associated with our lifestyle, and that is now affecting pregnancies in a larger perspective. Women were created to have babies ideally between the ages of 20 and 25. But today, how many of us actually get pregnant or married at that age? Most women are getting pregnant after the age of 30. By then, a lot of their ovarian volume or their oocytes or eggs are already haven't gotten utilized in their best reproductive years without any result. By the time they actually plan a pregnancy, they have gone into their 30s and conceiving itself is becoming a problem. A lot of women, approximately about 17 to 18% of our general OPD volume, have got patients who have conceived after some kind of medical help, where conception itself has been difficult and they required assisted reproductive technologies to get pregnant. Medical disorders like diabetes, hypertension, polycystic ovaries, renal disease have complicated pregnancy so much that what initially started off as a normal physiological change in a woman's life today has become a very big challenge for the hospital, the obstetrician, and the patient herself. Very big volume of high-risk patients are generally referred to a tertiary care center which has the infrastructure to support them. So if you look at the class of patients that you're dealing with, especially our class at the Dr. H Hiranandani Hospital, I would say about 27 to 28% of our patients go in the high-risk category. Whether they are already high-risk the day they conceive or during the course of their pregnancy, they develop complications and a normal pregnancy then gets converted into a high-risk category. High-risk pregnancies, like I explained to you, are pregnancies which by themselves have been associated with assisted reproductive technology to get pregnant. These women obviously have had a pre-existing hormonal imbalance and hence require very strict monitoring during the pregnancy to prevent unnecessary pregnancy loss. The second one is medical disorders like hypertension, diabetes, renal disease. All of these in pregnancy, either developed or pre-existing, require a multidisciplinary team approach where a physician, an endocrinologist, a gynecologist, all of them kind of work together, seeing the patient as a team to be able to ensure an adequate or optimum result. A large number of patients, approximately about 6 or 7% of patients in our OPD, are presenting with more than 2 or 3 losses while they're planning their pregnancies. Nobody plans a pregnancy to lose it. And when they've gone through it repetitively, twice, thrice, maybe more, they definitely become high-risk pregnancies. Challenges are one, dealing with the patient, explaining to her problems, explaining to the husband, and the biggest challenge is explaining to the family. Pregnancies in India are not only about the couple. It is like the entire family and the vicinity and everybody in the neighborhood has a comment to make on the pregnancy. Doctors have to deal with the Indian myths which are associated with it, plus actually literally chart down diet, exercise, medications in such a way that the patient is confident about what she's doing to land up with a healthy baby. At the end of it all, every obstetrician and gynecologist only wants for that patient what is best for her. The outcomes are very, very dependent on what is happening through the pregnancy. Like we have a patient right now who's waiting, who is all of 41 years old. She's had one normal delivery 13 years ago. This one was a spontaneous conception, developed severe pregnancy-induced hypertension, and today the blood flow from the mother to the baby has gotten stopped. So there is absent flow to the baby. She is only 30 weeks pregnant with a 1.4 kilo baby. Now, if you go there and you tell them that you may require a cesarean section to deliver this baby, and or you require medications to accelerate maturity, because you cannot wait up to the normal 9th month in this woman because you'll end up losing the baby. The family will all stand up and yell saying, no, these are today's doctors. They want to try and get the baby out early. It is not that. You have come with a problematic report. So if I don't act on it, you will end up losing the pregnancy. So challenges today are many. A lot of them can be covered or can be crossed over with communication, but there has to be a two-way traffic where the understanding is good from even the family and the relatives, where whatever the doctor is saying is obviously for your benefit in terms of your diet, in terms of your medications and hospitalization. Another thing that is very important is a proper tertiary care center with an infrastructure that can support delivering these patients and a backup neonatal intensive care unit. We at the Dr. H Hiranandani Hospital are really blessed because we have the backup of an adult ICU, a neonatal intensive care unit, a blood bank, and all of us consultants who are in-house here from 8 in the morning to 8 in the evening. So any kind of emergency, we are ready to face. For the high-risk pregnancy, we have got a completely certified lab for our blood tests. We get our reports within the hour in emergency patients. We have an intensive care for the adult. So in case the mother has excessive blood loss, very high blood pressure, fits during pregnancy or eclampsia, you have the backup to put her into the intensive care. You have the physician, you have the intensivist, you have the obstetrician, all present at the same time. Unlike other hospitals, the patient and the relatives don't have to go from door to door to meet various doctors. Here, we all sit together in the OPD, patient consults at a single payment, and we present the entire case with the medical as well as the surgical management, the protocols, and the likely outcome. Everything explained. Like I told you in the case that I was talking about, the neonatal intensive care unit now will, the consultant will sit with me, explain to the family how important it is to get this baby out early, even if it means at 7.5 months, rather than wait and land up with a compromised baby.